السلام عليكم ورحمة الله وبركاته. Our topic now will be one of the teaching methods, which is very important, problem-based learning, BBL. It will be illustrated by me, Dr. Ayman Al-Ashqar, FEMAR Fellow 2020. Introduction for problem-based learning. The process begins with a patient problem. It may be a written scenario or virtual patient meeting, for example. Number two, students work in small groups, sometimes called tutorial groups. 6 to 8 students per group are the optimum number. These groups aim to make students work in teams, which is a very important value we need to implement in the future doctors. Teamwork. Number three, the small groups are moderated by one or more faculty facilitator, and we should emphasize on this facilitator. So in BBL, we need a faculty member who guide the discussion. Number four, students determine their own learning needs to address the problem and make assignments to each other to obtain necessary information and then return to report what they have learned and continue with the problem to reach the final debriefing. So for good problem-based learning, to get the optimum benefit, we need 2 sessions. In the first session, we discuss the outcomes of the patient problem. Then the students make assignments for each other, go home, go to textbooks, read, prepare themselves, then return again to discuss what they read and what they learned to share knowledge between each other. Number five, student evaluation occurs in small group session and is derived from input from self-assessment, peer assessment, and facilitator assessment. This is an example of the BBL room in which we have from 6 to 8 students, and in some colleges it may reach up to 10 students. There are 3 characteristics of problem-based learning. Number one, the problem, which is the stimulus for learning. Number two, the tutor or the faculty member who act as facilitator for the discussion. Number three, group work, which is the core value of the problem-based learning. Then, how to organize a problem-based learning tutorial using Maastricht 7-step method. Number one, identify and clarify unfamiliar terms presented in the scenario. Scribe lists those that remain unexplained after discussion. So it is very important for the students to assign at first the leader and scriber, then make silent reading, highlight the difficult words, unfamiliar terms, then the students will make loud reading and start to identify and make discussion to clarify the unfamiliar terms. This is step one. Step two, define the problem or problems to be discussed. Now the students become more and more focused. They start to define the patient problem and start to identify the cues for this problem. Number 3, brainstorming session to discuss the problem, suggesting possible explanation on the basis of prior knowledge. Students draw on each other's knowledge and identify area of incomplete knowledge. Scribe records all the discussion. Then after this, we reach step 4, in which the students review step 2 and step 3 and arrange their explanation into tentative solutions. Then scribe organizes the explanation and restructure if necessary. Start to rearrange the specific learning outcomes they need to discuss in the next session and so on. They start to prioritize the problems. They start to make refining the cues for the patient problem. Then step number 5, formulate final learning objectives in order to be learned at home, and the students come ready for discussion in the second session. Then step 6, it is a private study. Private study. All students gather information related to each learning objectives. Then step 7, in the second session, group shares results of private study. Okay, so we can call PBL as a type of self-directed learning, because in PBL, after reaching learning outcomes, each student go home, start to read in specific textbooks. They read many and many information. So it is one of the favorable methods of learning, especially in the foundational years. Then characteristics of the patient scenario or the patient problem. There are 7 qualities required of an appropriate PBL problem. It should, number 1, a common problem that graduates would be expected to be able to handle. For example, we can bring a patient with diabetes, patient with hypertension, and so on, in order to make it interesting and motivating for students, not to select a rare syndrome. So the students don't know, and maybe it is not motivating for them. Number 2, serious or potentially serious. So it will motivate students to search and know how to interfere with that scenario. Number 3, the problem should contain enough diagnostic material and introduce basic principles of therapeutics. It is important when giving patient scenario to highlight some diagnostic procedures and techniques the doctor in the scenario suggest, like vital data, like lab investigations, like ECG, EEG, and so on. Number 4, which is very, very important, wherever possible, normal references values should be included when results of investigations are given. For example, if you give the vital data, for example, blood pressure, if you give of the patient is so and so, you can give the normal range of blood pressure for this age group. If you, for example, give sodium level, potassium level of the patient, please, as much as you can, give the normal reference in order to make a good and complete data for students. Number 5, have implication for prevention. it is important to bring scenario for a disease that could be treated and prevented in the future, but not to bring a problem with uh, unavailable therapies. It is difficult for students, not motivating for students to discuss and search for. Number 6, provide interdisciplinary input and cover a broad content area. It is important, for example, to make a mix between different departments. For example, if you want to bring BBL about an anatomy topic, for example, maybe you bring a scenario about trauma so that you can make the mix between the anatomical data and later on highlight probable surgeries, probable investigations, and so on. So it will mix the basic science with clinical science. Number 7, lead to an encounter of faculty members' objectives. Of course, each problem has an objective or group of objectives. So the quality of scenario that lead students to suggest and discuss these objectives is a good scenario. Have a degree of complexity appropriate for students' prior knowledge. It is important to make the difficulty of the scenario and the details in the scenario appropriate for the student level. For example, students in year 1, year 2 need simple scenarios, while students in year 4, year 5, you can bring much more complicated and difficult scenarios. The case should not require more than 90 to 120 minutes of discussion time during the 2 tutorial sessions and the interim self-learning period of few days. I think learning outcomes or objectives that could be learned through 3 days preparation is good. It is wise to have few possibilities in order to create a bank of cases to avoid recycling the cases more frequently than one every 3 to 4 years. This is very important to avoid getting the ILOs or SLOs from the previous batches. So it will encourage cheating. But if you have good bank for BBL topics and BBL scenarios, in order not to repeat the same scenario except after 4 years, for example, I think it is difficult for the students to get the previous scenarios from older patches. The structure or format of the problem, it can be relatively unorganized in order to enhance students to think about differential diagnosis and so on in proper synthesis, open-ended to promote application of clinical reasoning skills and will also be more motivating. Sources of problem, there are several resources from which PBL cases can be obtained. We can suggest MEDIT portal is a resource developed by the Association of American Medical Colleges. And this is the link for MEDIT portal. The tutor guide for problem-based learning. It is important to have a tutor guide. This guide is as title suggests, to help BBL tutor or BBL facilitator who are not content experts to facilitate the BBL sessions in a competent manner. Give him some knowledge in order to be able to guide the discussion. Intrinsically, many BBL tutors also find themselves learning from these guides, which is important. If you facilitate BBL regarding anatomy, regarding pediatrics, regarding internal medicine, regarding physiology, here facilitators reach the interdisciplinary approach of integrated learning. This guide should contain the following. First, full description of the problem. Number two, all the diagnostic materials, glossary for specific terminology, and phenomena and specific learning outcomes that need to be explained. List of important concepts with short explanation, the limits of the problem, a list of possible questions in order to encourage discussion between students, a hypothesis scheme. The tutor guide may include issues that need to be avoided so that the students don't get distracted from learning objectives for the particular case. Difficulties in BBL. It is difficult to ensure that all student groups achieve the objectives of the cases, particularly for cases that are relatively unstructured. So in BBL, studies show that BBL accept many tangent readings. Sometimes some groups reach group of objectives and their colleagues reach some objectives like their the first group and some extra objectives. Selection and training of facilitators. As a start, selection in the original McMaster BBL curriculum, Neville and Norman stated that tutors were not required to have any particular content expertise other than that contained in the tutorial guide. So it is not necessary if the BBL talk about an anatomy, for example, or physiology topic, it is not important to bring an anatomist or physiologist. No, you can bring any doctor, but give to him the tutor guide. In subsequent research, several studies found better learning outcomes if the facilitator or tutor had content expertise. So this topic is now controversial. There is a controversy regarding content expertise, but the major or the majority of studies suggest the facilitator is problem expert, not subject expert. Seitz and Ball reached results that when novice first attempted problem-based learning, the outcomes are better if the faculty facilitator are content experts. However, after 1 to 2 months, students enrolled in BBL curriculum are so acculturated and so highly skilled in student-centered, so self-directed learning, that they are no longer so dependent on the facilitator. So in the first year, you can depend on content experts, but later on, and by growth of student skills regarding the self-directed learning, and they will be expert in the student-centered activities. You are no longer in need for the content expert. Then Sites and Paul further argue that in practice, it is not feasible for facilitator to be content expert for all problems that they will facilitate. Really, in the majority of colleges, PBL conducted by non-subject expert, but problem expert. Tutors who read the tutor guide, tutors who read in the textbooks, not necessarily a content expert. What they have found is the facilitator need to develop case expertness by facilitating the case between 3 and 5 times. I have argued elsewhere that what we need to determine is not whether tutor need to be content expert, but what is the minimum content expertise and group facilitation expertise needed for tutor to be effective. So now all talks, all conferences highlighting that tutor is a case expert, not subject expert. Training is crucial step in conducting problem-based learning. Facilitators need to be given specific guidelines about how they are to interact with students. Moving from content expert to facilitator is not necessarily natural for many faculty members. So practicing the role during training will be helpful. The use of standardized students, that's to say simulation. Individuals who are trained to act like students can make the practice closer to the real things than it might otherwise be. However, it can be expensive and the fidelity of the simulation to real life may be difficult to maintain. Facilitators should also be given all information about case and any associated readings or material that students will be given, as well as materials that will allow them to guide students in their search for knowledge. This includes the next step that students are expected to take. For facilitator, you should give them PDF textbooks. You can give them videos and other materials in which they can share with the students to facilitate their learning. How many facilitators per group? There is argument about this, but the most universal is one facilitator per group. But if necessary, if you have more than one facilitator, no problem. But the most universal and most accepted is one facilitator per group. The role of tutor in small group discussion. Number one, an instructor who is there to impart information to the students, give information directly to students. Number two, the devil's advocate who intentionally adopt a controversial view in order to stimulate discussion. Number three, neutrally chair, who literally chairs the discussion but express no strong opinion, leave the students lead the discussion. Number four, the consultant who is not part of the group but is there for students to ask questions if they have vague concepts, if they need to ask about major items in the scenario, they can ask this consultant, but he is more or less neutral and have minimal contribution. Then the last one, or the last model, is the facilitator. It is like the neutral chair, but with more of a guiding role. For example, asking the group open-ended questions to facilitate their progress with the task in hand. Reichmond defined more specific roles for tutors, which he referred to as strategic intervention. This medical educator suggests some roles, some strategic intervention for the facilitator, like to start and finish group discussion. Number two, prevent sidetracking, which is important in order to make the student focus on the main problem of the scenario. Number three, to manage group dynamics by encouraging the shy or bold students and by handling the dominant, aggressive, offensive, or nauseous student. And also to facilitate goal achievement through open questioning. Also to manage the group environment by keeping an eye on the time and dealing with any distractions, noise, insufficient, flip chart paper, pens running dry, heating, and so on. These are the reference for my lecture. And at the end, I'd like to thank you and hope that this lecture is valuable for you.